Hello, my name is Savinder Virk, and today we are going to be talking about strategies for regulation of blood glucose level. This is an article that will be studied to see what strategies help with monitoring decreasing HbA1c levels in patients. This is MSN 600 class. Dr. Anita Hunter was our teacher. I'm going to go to slide 2, introduce what we are talking about today. Diabetes is a disease that we are all familiar with. We might have or might not have a family member who's been affected by it, but we have all definitely seen patients who have been affected by this disease. It can just be limited to the pancreas, where the pancreas are not working properly, they're not releasing enough insulin, or we are just have become insulin resistant, where there is enough insulin in the body, but it is not recognizing the glucose and it's not collecting it from our system. Or we can have inadequate insulin secretion or inappropriate glucagon secretion from the liver. This is type 2 diabetes. Type 1 diabetes, it's an autoimmune disorder in which the beta cells destroy them. So according to Carduri, this is a disease that consists of an array of dysfunctions, which are characterized by hyperglycemia. So what does the CDC have to say about this? The CDC, the Centers for Disease Control and Prevention, report in 2017 30.3 million people of every age group were affected by diabetes. Diabetes, why is it so dangerous? It can cause kidney failure, retinopathy, neuropathy, heart failure. The reason why it can do this is because diabetes is both micro and macrovascular, which means it affects the big major veins in our arteries, and it also affects the minute, the very small veins and arteries. So the kidney and the eyes and the peripheral body system all have small arteries and veins, and when they crystallize, basically they shatter, they break, and they're gone, they're damaged forever, and hence causing kidney disease, eye disease, and nerve disease. So when this disease progresses to a point where the body can no longer compensate, that's when you can go into heart failure or you can have kidney failure. In 2012, the estimated cost mentioned by Asau in 2014 was 245 billion, which is 2.3 times than those of people who don't have diabetes. The International Diabetes Federation has predicted that the number of people living with diabetes will rise from 366 million back in 2011 to 552 million by 2030. I will not be amazed if we have not already exceeded that number. Hopefully we never do, and interventions do help. Slide 3 will talk about community needs. In order for any research project to be effective, we need to assess the needs of the community first. We need to know what the community needs, what the community feels like its deficits are, what we can fulfill with this research study. So 5 different psychometric measures were used: the Hopkins scale checklist with 25, the Diabetes Knowledge Questionnaire, Self-Efficacy Scale, the Diabetes Health Beliefs and Problem Areas in Diabetes Scale was completed. These questionnaires were completed by social workers that were available to see the patients in the clinic. And these questionnaires helped in addressing the disclosure of living with diabetes and lifestyle changes, which were used to triangulate the quantitative findings, according to Hall in 2016. According to American Diabetes Association back in 2016, providing education regarding disease process, self-care, and cost involved with the care are the 3 major components that the community identified. Community members also identified that access to community clinics, rehab programs, and therapy classes were not available to patients who had diabetes. They reported a lack of follow-up care and also said that diabetes was not affordable, that there was no way they can buy a meter that costs $70 or keep buying strips when they can't even afford their next meal. These were some of the needs of the community. So we on slide 4, you will see that we developed our PCOT, which is our Population Intervention Comparison Outcome and time frame. So our question was, among patients aged 19 to 66 with diabetes, do interventions like diet management, exercise, and supportive therapy help lower the blood sugar levels in 1 year as compared to patients who are non-compliant? So our population are patient adults 19 to 66 years of age who have high HbA1c levels and who are diabetic. Interventions are educational, physical exercise, diet therapy programs, diet management classes, diabetes awareness classes, proper exercise, and weight loss exercises. Something new that has been introduced are motivational text messages between peers and uh, primary care providers, along with cognitive behavioral therapy sessions. The comparison between the results will be done at the annual checkup from the initial screening, so with a 1 year difference. That is also the time frame for this study. There is a decrease in HbA1c levels in diabetic patients and more compliance in self-management. This is the expected outcome that we want from this research study. Going to slide 5. Why was this necessary? Why did we need to have this study? Why are not the interventions that we already have were working? What is the significance of this research that we're doing? This research will help us understand the ineffectiveness of the chronic care model, which had shown very high levels of decrease in diabetes, but it was not nearly as effective. The education system in effect for diabetes and what changes need to be made in order for it to be effective. It will also help us understand if behavior modification is necessary for diabetes control. So what was the background? What happened? What did we do wrong? There was a patient unwillingness to learn new methods for change, high turnover rate for staff nurses who could not teach these patients because there was a high overhead cost to train new employees, new processes, and new methods and new evidence-based research. There was a decreased nurse practitioner, primary care provider face-to-face time with the patient because of the patient influx, because of the huge medical deficit of doctors that we have. Doctors who are still in primary care in the primary care patient business see more and more patients every day, and more things slip through the cracks every day. There's no PCP and availability after certain hours. We are closed after 6 unless it's an emergency, or we direct the patient to the nearby ER. There's high patient retention due to high cost of medications and inconvenience of no nearby labs. There's a decreased reference for exercise, diet, and therapy. Many of times diabetics don't even get referred to dietitians until the matter has gotten very, very worse. And dare say, I don't think many of them get referred to therapy at all. No use of staff resources to ensure patient success. There's no use of the case manager saying, hey, this patient can't afford their medication. Is there something we can do about this? All right, slide 6. Literature review. Full-text peer-reviewed journals that were published in the last 5 years were used for this literature review. And they discussed many, many different interventions that were successful. So, a study done by Svetkova and Associates in 2016 about the characteristics of social psychological adaptation and self-regulation in patients with diabetes. So 50% of the 128 patient population that they had did confirm that patients with diabetes have poor self-regulation. Lifestyle changes after a diagnosis of type 2 diabetes. 95% population showed no change in blood sugar levels despite the change in diet and exercise alone. The impact of interventions on appointment and clinical outcomes for individuals with diabetes. The research of 211 articles confirmed that web-based multidisciplinary programs increase compliance in patients. This study was done by Nudi and Associates back in 2015. All right. The next slide is Methods and Designs, slide 7. An umbrella review of the literature was completed using the National Institute of Health, the Centers for Disease Control, CDC, Sinhal, Medline, EBSCO, ProQuest. Mixed methods will be used for the project. Quantitative data will be obtained, and it will be obtained using questionnaires, behavior regulation questionnaires. 6 principles of the chronic care model will also be used. These will be conducted by therapists, and some of these questionnaires will also be conducted by nurses, especially the chronic care model, because it applies more to ADLs that are performed by the patient. Qualitative data will be collected via the patient's email, text, and video chatting with the research staff, which can be a nurse, a dietitian, or a physical therapist, depending on whether they're talking about their daily diet, exercise, whether they're talking about coping strategies, or their medications that they have questions about. This will be completed. The patient can send an email to the office and the researchers will go ahead and respond to this patient, asking them questions or seeing how they are doing with their coping strategies. Are they still with the program, or have they found it, or have they lapsed something? So at the end, a correlational analysis will be conducted to establish the relationship between the two factors, the interventions and the blood sugar levels. So we will see whether our interventions have been effective in lowering our blood sugar levels. So what methods and designs that we still used? Continued on slide 8. So the study is being completed with 50 patients of ages 19 and 66 who will have random height, weight, race, and gender. The only common factor will be high HbA1c levels. Health data like their HbA1c level, weight, anxiety, depression level, and diabetes education level will be collected at the beginning of the study and compared at the 1-year mark during their exit interview. These results will basically predict the outcome of the study. The two variables will be the interventions and the blood sugar levels will give us our correlational analysis. The site for study will be the community clinic that has a mixed variety of patients from different races, socioeconomic statuses, ethnicities, cultural systems, and all other patients that have comorbidities will be excluded from this study. Slide 9 talks about our theory model. So what theory model did we actually end up using for this research? We used Virginia Henderson's theory, which mentions that the guide of development and implementation of the proposal about moving diabetic patients to a healthier state by helping the patient gain independence concerning the activities that lead to better health or recovery of health, according to Ascham and Jacqueline in 2015. So Virginia Henderson had 4 central concepts, which consisted of the individual, environment, health, and nursing, and it'll be addressed in the proposal in the following ways. The individual concept means that any component, whether it's biological, sociological, or spiritual, affects the human being as a whole and is required to be at a stable, peaceful state for the patient to be healthy. So if patient is physically not well, then it's going to affect them mentally as well. Or if the patient gets a diagnosis of diabetes, spiritually they might question why this has happened to them. So these are the things that we need as nurses will be watching for, or the researchers will be watching for. Environment. The researchers will conduct interviews with patients using questionnaires that ask questions about how the patient sees their environment. What is their family relationship? What is their financial situation? What type of housing do they have? These type of things matter very much, and if the patient is not sound and doesn't have a positive outlook towards these things, it can really affect their care. The health concept is basically how does this patient do their ADLs? What is their idea of them being able to perform their ADLs, being able to take care of themselves? And how the next of kin thinks that this patient is able to take care of themselves. These will be evaluated with the patient to set a reality treatment plan. The last concept of theory is nursing, which tells us that the nurse practitioner or the nurses will help guide the patient through these interventions and substitute for patient care until the patient is able to take full command and able to take care of themselves. Slide 10 talks about proposed interventions. Diet management. The researchers will be setting up the patient with a dietitian to teach new and effective methods to lose weight, eat healthy, and maintain acceptable blood sugar levels. Physical therapy, gym membership, yoga, running, jogging. Newer innovative methods will be taught to the patient, and whatever the patient feels culturally and financially able to do will be the ones that the patient can adopt, so that the patient can also have equilibrium with environment, but also make sure that they are healthy. Therapy. A patient's internal and external environment needs to have a balance. So motivational text therapy can help the patient stay on track with when they're connected to a buddy system, so that one buddy can tell the other buddy, yes, I'm doing good today, or no, I'm not doing good. Let's talk about this. This type of therapy helps create positive, it's a positive feedback loop. Yes, this is great. Yes, I can continue with this. Or yes, you can do this. Or let's try something different. This is the type of therapy that is really needed to see behavioral change in an individual. Along with this, teletherapy review of behavior will also be conducted every month by a therapist for the patient. Slide 11, results. 50 patients were chosen for the study. They were aged between 19 and 66. They had a body mass index of 25 to 43. This is the body mass index that we are looking for, and they will range from overweight to morbidly obese. At least 70% of the 50 patients who followed the interventions should have decreased HbA1c levels. There should be a decrease of BMI, and the patients should have more education about diet control, proper fat-losing exercises, and coping behaviors to manage anxiety, depression that lead to overeating or stress eating. Conclusions. The expected outcomes of this project are expected to be similar to the past studies. There'll be an increase in knowledge about interventions, a decrease in HbA1c levels, good health management skills for patients, coping strategies to modify behavior and decrease food obsessions, physician anxiety or provider doubt regarding role in management of disease will also be decreased as well. So physicians will have a lot to learn from this study so that they can actually guide their patient towards the right direction. They can give them the right resources, and they can have the provide their patient with the proper education as well. So implications for practice. What needs to happen in order for this to be effective and be in practice? So first of all, implementation of these interventions will help increase compliance with diabetes patients, which may eventually decrease the blood sugar levels and keep the long-term HbA1c levels in control. It will help educate patients that proper diet, right exercise, and cognitive therapy can help them choose a healthier lifestyle and prevent comorbidities. It will also educate patients that behavior is a major factor in control of habits that lead to noncompliance. Hence, patients will seek out behavior modification strategies and request them while visiting their primary care providers. This is the biggest reason why this is not done. Patients think that mental health is a stigma, and if I tell my doctor that I feel depressed or I don't feel happy, that I will be marked crazy, or I'll be like, people will say bad things to me. This is the stigma that we need to get rid of, and we need to help our patients feel better about talking about their mental health while talking about their physical health as well. So, you've been diagnosed with diabetes. How do you feel about this? Do you think you have a way to cope with this? These are the questions that need to be asked. Do you have a support system? So having on-call nurse practitioners that can attend patient phone calls and emergencies in a timely manner will also decrease ER visits. Providers will offer samples to patients for medications that are expensive to reduce loss for allergy and effectiveness problems. Sometimes patients go and buy medications and they end up having allergic to it, and they actually made a copay towards that, which can put a deficit in their pocket and their health care. Therapists will give out more learner-friendly brochures, mobile app connections for better learning outcomes. Nurse practitioners will also increase interaction time with patients and provide proper on-site references to other doctors and social workers, case managers. The dietitian will provide opportunity for patients to choose meal plans and make healthier choices. The physical therapist or gym instructor can help a patient choose right exercises for maximum weight loss while teaching proper technique. So this is the biggest thing for this research. This is the biggest thing for this research study. All of this needs to happen in order for us to realize that yes, diet, exercise, and therapy can help make a difference in a patient's life and make diabetic patients compliant. Thank you.